So, Frida Lundmark, you are back, and I should also say welcome back to the afternoon session that we kind of sneak started here. But we will continue here, and you will take the lead for the next session.
Yes.
Right, and
yes.
you are the policy expert at LEAF, as we already has presented you as, and I will just leave the floor to you.
Thank you.
My guest.
So we are now shifting to perspectives from treatment to prevention and early detection. And yes, chronic diseases is increasing all over the world with significant impact not only on individuals but also on healthcare systems, and not the least in the light of the COVID-19 pandemic. But what does it cost not to focus on prevention and chronic disease management? And how can we contribute to shift from treating sick patients to a healthy population? And how can we promote preventive work in healthcare, and how to reimburse that work? And how can we develop precision early detection? We will dive into two different but related themes during this hour, and that is lifestyle and prevention, and that is also how a sustainable and resilient healthcare system handles early detection and chronic disease. And to join me here on scene we have Johan Karlsson, and we will also like to welcome Dr. Shirina Al-Mazrei. Please welcome up here on stage. That is Director for Health Promotion and Public Health Programs Department at Abu Dhabi Public Health Center. So, perfect. But to kick off this hour, we will start to inviting Dr. Abdullah Rasood Al-Gwizani that will join us digitally live here, if we have him. So maybe he's not. Oh, most welcome. And Dr. Abdullah Al-Gwizani is from the Public Health Agency in the Kingdom of Saudi Arabia. So most welcome. And please,
Hello,
the stage is yours.
I'm happy to be with you.
So you will start by giving us your thoughts and give us your short presentation of your experiences in this related area.
Sure. Is my voice? You can hear my voice?
We hear you perfectly fine.
Sure. Thank you very much. It's my pleasure to be here with you and in Dubai EXPO. And thank you for Professor Johan for the arrangement and invitation. I'm happy to be with you guys here. Chronic disease is by far is the most costly to treat disease in terms of burden, and also the impact in the health system. It's not. It's a global burden. It's a global issue that's been challenges in all over the world. For example, the expected annual cost of non-communicable disease in Saudi Arabia is around 9 billion, which is almost 1.6% of the GDP. The raising of the non-communicable diseases are concerning in all over the world, and Saudi Arabia is no different in that. We recognize that as a young nation that we need to, and this is something that I think most of our GCC countries is experiencing, that we are relatively young population term. So we are moving with this generation to and the future impact, and that's need a real understanding, and also important intervention that focuses on the prevention, not the treatment, because no treatment will be ever sufficient to tackle or address this disease. So in terms of that, the Vision 2030 for Saudi Arabia has focuses on prevention plus the treatment, but the shifting to prevention with three major goals, which is one, to improve the access to health care, prevent from the any health threats, and improve the quality and of the care that is being delivered. And we, with the ambitious goal, with the goal that it's raising the life expectancy at birth from 74 to 80 years by 2030. That we need to work in the has led to reforming or starting the reforming process in the health system, where it relies on accountable care or delivery organization that focuses on the value base, and one of them is a new model of care that focus on the value base, that will address prevention and will have the needed process for reimbursement as well. And one of the goal or the projects or the initiatives that has been in place now is the formation of the Public Health Authority of Saudi Arabia, and the goal of the public health is to work in the with this development stakeholder in the shifting the helping the system to be the scientific advisor, the regulator of the public health prevention programs as well, and to help to mind shift this one to the prevention. And we did kick off several strategy and program that addresses screening and also managing the risk factor in terms of increasing the physical activity and reducing the tobacco, and also helping with the Ministry of Health also to optimizing the primary health care. But also recognize that is the burden of or fighting non-communicable disease is not only an health file, it's also it has a lot of things outside the health sector. In working with the behavior science in order to change the perspective and the behavior and toward the risk factor, and also work with the other regulator or government agency for taxation for bad or harming product as well, and also helping to foster certain initiatives in a way that it can help shifting the whole population and help them choose the healthy choice. This is a long-term, let's say, public health battle that we need to take it all, and we are working here as a public health authority to help the decision maker also, and also the about monitoring and evaluation of this program, and try to deliver the scientific and try to reach this needed goals. Thank you very much. This is what I from my side, and I'm happy to answer any question. Thank you.
Thank you very, very much, Dr. Abdullah Galguzani. Thank you very much for joining us here today. So now I'm turning to the panel that we have here on stage. And Johan, we heard from you, and now I'm turning to you, Dr. Shrina. Can you please just give us a short introduction to you and to your work?
I'm Dr. Shrina Al-Mazroui. I have worked in public health for almost more than 10 years. I lead the health promotion and public health programs in the Public Health Center of Abu Dhabi. The topic is so dear to all of us because we work from prevention perspective rather than work on disease-based issues. Working from the start with people to live healthily, take responsibility of their health, become a better version of themselves as they grow more and more in life, rather than to wait until a disease or an issue occurs, a problem occurs that requires attention of the medical care. So these are the most important things that we want to focus on.
So I know that you work with diabetes and metabolism. And
not the diabetes per se, it's mostly the screening and prevention, yes.
So what would you say that, what are the most difficult for people when it comes to changing lifestyle and behavior?
First, the acceptance that they have an issue. I mean, for example, with screening, we've discovered people who have never known that they have cholesterol, hypertension, or diabetes itself. The denial phase is the difficult phase for them to start accepting and then working towards changing their lifestyle behaviors. They have been living for so long on certain dietary habits, sedentary lifestyle. With the modernization, people tend to use electronics, stay at home, and avoid doing any exercises or work around or even join any community-related activity like a walk or a run or a simple activity within the communities, though it is available in the society. So most of them took almost 6 months to a year to absorb that they are diseased and then start changing. But in that term, you need people around. The environment as a whole needs to be changed. The people around in the same house, for example, the dietary habits cannot be changed for a single person within a whole household. It has to be changed and maintained, and it has to be continuous. Even the physical activity. The community that they live in has to provide, for example, path or cycle tracks or whatever is needed to support them to walk around if they cannot join a gym or become a member in any heavy sports activity or medium sport activity. So it took a long while, up to a year, for them to accept. Changing then starts to happen slowly, as long as there is a family or support from the surrounding environment.
So, Dr. Johan Karlsson, if we are looking at the societal level and sort of a bit on the same theme, what criteria would you say are the most important to decide and scope and shape of preventive measures in a country? Is it health, or is it healthcare cost, or other factors?
I totally agree with my colleague here that saying you need to work on the societal level rather. The medical sector, the health sector cannot solve the health problems. The health sector could probably help out patients, hopefully, when they are ill. They could also assist in supporting change of lifestyle in the patients. But the basis for a well-functioning public health system is to try to determine what will govern the outcome of health, sort of identify determinants here. And I think being in this part of the world is not so difficult to see how things could be improved. I mean, it's the same at home, but it's same. It's not that people don't want to do things; they don't have the ability. They don't have. How do you bike in Dubai? How do you run in Dubai? I've been working with the Saudis for 10 years now, and they've made a remarkable shift in the society when it comes to looking at prevention on the societal level. And I hear it's the same here. But I mean, you have to build a society where people could use or have use for their interest in moving, physical activity, biking, doing things. And it's also very much, when it comes to Europe, for example, where it's easier. I mean, it's greener, it's not that hot, it's not 45 degrees in summer. It's very much of a socioeconomic factor here. We know that people with lower socioeconomic status have the health problems more than other people because they're not used to taking care of this. They haven't got the ability. If you live in a suburban area, so it's boring suburban areas with very little to do. I mean, how could you do? You don't have a tradition of doing things, of skiing or moving around as a lot of people in Sweden have. So we need to work on these things, and that's education is very essential. The schools to teach the pupils about how do you take care of yourself? How do you develop these things? But also how you build your society, all areas. We have tried to develop a supportive system, we call it. We have launched for the use in the regions, for the use in the cities, communes, to address the most important factors that will lead to better health. And it's not for the health system only, it's mainly for educational system, building system, planning system. And I think you're along the same line. You have to concentrate on that to get it. And that's also what we really a little bit build our strategy in the COVID, because the COVID is a NCD, non-communicable disease, rapidly moving. It's very much the same. As antimicrobial resistance or tobacco, which is even worse. Of course, many more people die from tobacco than will die from COVID. We have to realize that.
So, Dr. Shireen, and what from your learnings, do you agree with Johan, or do you have other aspects to add? What are the successful factors to do prevention?
I totally agree, actually. We stress as well in Public Health Center on the health promotion and awareness extensively and massively, which was even done throughout the year with a remarkable team that I was lucky to have. They've been able to change a lot of people's minds on COVID itself, how to protect themselves, leading a healthy lifestyle, because with quarantine and isolation, people are being stuck somewhere and they cannot they say, I can't be healthy while I'm just staying in one room, for example. They've been able to help them read, exercise, eat healthy while they are on isolation. And the policy is an important factor, because as we push policy, and specifically the payers, to incentivize providers on the preventative side rather than the only focus on the curative, then they will be attracting people to do screenings, continuous, not ad hoc, episodic, continuous screenings, health-related checkups, and having even appropriate feedback from providers on time rather than coming late.
Thank you.
Thank you.
And with that, I would like to thank both Dr. Johan Karlsson and Dr. Shireen Al-Marzai for your participation in this panel. Thank you very much. Before moving on to our second theme, we will now continue with a short film from Astrazeneca. So, chronic diseases such as heart diseases, cancer, diabetes, and chronic kidney diseases are the leading cause of death and disability all over the world. And the problem is often that chronic diseases is diagnosed at a very late phase with a poor outcome for the patients as a result. And what can we learn from the COVID pandemic in terms of from the pandemic response, and how can we make sure that chronic diseases are diagnosed at an earlier stage and treated earlier for a better outcome for the patients? Our next two speakers represents the Partnership for Health System and Sustainability and Resilience, which was initiated by the London School of Economics and the World Economic Forum and Astrazeneca in 2020. And this initiative was motivated by a shared commitment to improving population health through and beyond the COVID-19 pandemic. And since then, also Philips has joined the partnerships, and this partnership is also actively seeking new partners. And with us now, we have Digital Alive, Professor Alistair McGuire from the London School of Economics, who has been heavily involved in this collaborative project, motivated by the shared commitment to improved health throughout and beyond the COVID pandemic. And of course, we are very curious to hear more about what you have done and what you have learned so far. So a warm welcome, Professor McGuire.
Hello. Good afternoon. I don't know if you can see me. I can't see the stage, but there should be some slides up, and you may even be able to see my image.
We see you perfectly fine, and your slide deck is also present here.
Okay. Thank you very much. Okay, so thank you for the introduction. The Partnership for Health System Resilience and Sustainability is a public-private partnership. As you said, it's a partnership of global researchers, which we coordinate through the LSE. It has resourcing bodies and policymakers as well. And it's rolling out across a number of new partners, and it's an open partnership, so we welcome everybody into the partnership. And we have about 30 country teams globally, including Saudi Arabia and the UAE, within the local region, so we're still expanding. So today, I just want to talk a bit about your theme of chronic disease. We have started looking at that, but I just want to give some background. So the next slide, please. This slide should be saying what is chronic disease, and of course, the pandemic has highlighted the multimorbid aspect of chronic disease. It's chronic disease itself is actually still open to interpretation. Some interpretations include diseases like COPD, so upper respiratory diseases, but others don't. And of course, all healthcare systems are facing an increasing burden of trying to manage chronic disease. Globally, for the over 50s, the major chronic diseases are the big killers: ischemic heart disease, stroke, COPD itself, diabetes, and chronic kidney disease. And the graph that you can see on the right-hand side shows that since the 1990s, these chronic diseases have been growing fairly rapidly over time. And not only are the diseases themselves growing over time, but if you have a chronic disease, you're much more likely to have comorbidities. Within the UK, for example, over 2/3 of the population over 65, if they are diseased, have a comorbidity, and 50% of those have 3 or more comorbidities, so that even when chronic disease is diagnosed, it becomes more complicated and difficult to treat. And of course, as I said earlier, the pandemic has highlighted the multimorbid aspect of that. About 45% of those who contracted COVID in the USA, for example, were comorbid. It's going to have an increasing cumulative impact on global health because we're seeing about a 1.5% annual rise in metabolic risks, high BMIs, high blood sugar, blood pressure, cholesterol since 2010. And if you're growing at 1.5% per annum, by about 30 years, you've doubled the number of individuals with metabolic risk. So it's an increasing problem in the world. It's still the major killer in the world. It accounts for about 20% of total health loss worldwide, and that's 50% higher than 1990s. So it's contributing to roughly 1 in 5 deaths. And I wouldn't say any health system is coping with this presently. Next slide, please. Obviously, one of the problems is that a number of individuals with chronic disease aren't picked up by the system until an advanced stage. And obviously, if it's more advanced as a disease, it's more difficult to treat effectively. So the obvious question is, why not screen and try to prevent, detect more of these chronic diseases in an early stage? Well, there's a number of problems with that, obviously. The first one being something that some of your guests have already alluded to, that prevention and screening is population-based. It's not individual-based like healthcare itself. And as it's population-based, first of all, it's more difficult to coordinate the resources to put in place prevention and screening programs. And also, because it's population-based, it may be that you don't actually identify the high-risk category groups until sometime into the future. And indeed, whilst you're tracking them through time, the benefits from healthcare may not arrive until some point in the future. And I'll come back to that in a moment. But I think one of the things to point out is there's always a trade-off when you're screening or trying to detect at an early stage some disease between the detection rate, the sensitivity of the screening, the false positive rates and the true negatives, the specificity of the screening, as well as the cost of screening. And costs, because we're looking at population-based interventions with detection and screening, can be rather high. Now, as I said, the chronic disease prevalence is increasing globally. So early detection, all other things held equal, will have a higher predictive value because you've got more prevalence of the disease. You should be, all other things held equal, better able to pick up disease in its early stage. So if that's occurring, what stops us from picking up early these diseases? Next slide, please, the last slide. Well, I think there are a number of issues here, a number of issues stopping early detection or screening with chronic disease, even if we're able to, even if we effectively have screens or detection tests in place. And for some of these disease areas, it is getting, there is improvement in the screening for these chronic diseases. So we should be able to pick them up earlier. But there's a number of issues. Healthcare budgets, of course, are geared towards the short term. There's more emphasis currently on cure rather than progression and through prevention. So particularly the budgets are focused on yearly accountancy type balances through the balance sheets for healthcare rather than planning for long term. So we need to link finance to long-term outcomes and early detection in particular. And one way in which you might do that is through trying to see prevention as an investment and therefore put into the finance, the one-year finance budgets, some investment associated with prevention, which at least would attempt to align long-term outcomes with short-term financial planning. Of course, as I've said, prevention screening is population-based. And I think the last thing I'd say, and again, people have touched on this in the earlier in the day, whilst it's true that a lot of these diseases and the prevention aspects focus on individuals and individual behaviour, it is the case that many of these risk factors are preventable and treatable, but they're obviously highly interrelated with social issues. So they're not only solely related to healthcare. Social issues such as social inequalities, food policies, housing, even exercise, as was mentioned earlier. These all come into play, and individual behaviour comes into play. And yet within governments, budgets are siloed. You know, the housing budget, the food policy, or inequalities, social inequalities budgets are siloed from healthcare. So there's no overview necessarily given. when healthcare started to be introduced into societies at the beginning of the 20th century, public health was really high on the agenda, and that seems to have slipped off now. It's coming back because of COVID, and we have to take the opportunity to use that rebound with public health to try to get some overall coordination across all these policies. So I think that there's a number of messages here. Chronic disease is rising. In some cases, we can prevent and treat very early, but to do so, we need to screen. That's difficult because of the population-based interventions, but also a lot of these diseases are comorbid and related to social inequalities, which we have to address as well. So thanks very much for giving me the time to address you today. I'll hand back to you.
Thank you very much, Professor Maguire. And we do actually have time for one question. So allow me to ask you, how do you see on that, does health system sustainability require moving to preventing disease progression for chronic disease? Do you see that as a prerequisite?
Well, obviously, the later you intervene in any disease, the more complex it becomes and the more costly it becomes. So the earlier you can intervene, the better. Prevention's better than cure, right? Everybody knows this. It's a method, it's how you get the means and the methodologies to allow you to intervene early, which are important and complex. And as I say, I basically try to marry up the financial system, certainly within the healthcare budget, with long-term outcomes such as the benefits, the health benefits that arise from screening, by putting into the financial budgets a line which says we have an investment in prevention here. And every year we do that. And if you do that, then you get cumulative investment into prevention, into public policies, public health very early on, and it's cumulative over time, which is what we need because these diseases are growing at a cumulative rate. So yes, to be sustainable, you have to do something.
Thank you very much, and thank you for joining us here today, Professor Maguire. So, second out in this panel is I'd like to introduce our next speaker, that is Pelin Inzesu, that is Area Vice President for Middle East and Africa at Astrazeneca. A warm welcome to you. The stage is yours.
Thank you. Maybe I should stand up. It's much better in the afternoon, huh? So thank you so much for, first of all, for the organizers, for Swecare, for organizing that sort of a really exciting initiative for today, this meeting. It's also an honor working on the stage, talking on the same stage with the Professor Alistair Maguire, which is, we are proud of sharing and partnering with that great project with them during the last 2 years, actually. And thank you for you being here physically, personally, under this great weather in Dubai, and also who actually attending, joining virtually on this great panel, this meeting virtually across the world. So thank you all. Actually, it's obvious that we are all aware that COVID-19 placed unprecedented strain on our health systems across the globe. And it was actually a big test for the human being, for mankind, for all of us. And we are still trying to deal with that shock, with that crisis, working all together, how to recover, how to overcome this challenge for the human beings. I use the word together because I think this is the key word maybe for the 2.0, for the second phase of our lives within the next couple of years, maybe for the future of our kids. We should be really thinking and reviewing our lessons learned over this pandemic. One of the main outcomes of this last 2 years is we have to work all together as all the partners, all the stakeholders in this ecosystem. For Astrazeneca, to be very open, it's not a new concept. It's not a new thing for us, as we have been actually committed ourselves to working in this operating model since many years, working with different functions, putting the patients in the center, and across this, around these patients, just putting all the relevant stakeholders and partnering with them. And keywords, if you ask me what are the 3 keywords, I would be saying that helping and contributing to the societies through innovation, through partnership, and through expansion. So more contribution to the societies. I'm sure that all partners will be benefiting out of that. Having said that, of course, it is really important whom are you partnering with, because we need to partner with the right stakeholders, with the right partners, sharing the same commitment and the same values with yourself. And then this gives you the speed and the common goal in order to having the results in an earlier space. To this extent, we feel we are so lucky, and we feel that we are really successful in this journey, but still most of the journey has not been completed, and in the coming years we will see more that sort of an approach across the ecosystem partners, just not a couple of projects. PHSSR is one of these very good examples that we are very much proud of, being a part of this project for the last 2 years, which initiated by London School of Economics and World Economic Forum, and now Philips is joining to this group, and more partnerships we will be seeing in due course. And yesterday I had the privilege to listen to the PHSR summit during the Health Resilience Summit here in this Swedish pavilion. And it was really inspiring and really exciting for all of us to listen to the countries who joined to this project. 7-8 countries shared their first initial outcomes of this project, how they really looked at their local systems, healthcare policies, and regulations, and what can we do in order to avoid future shocks, not necessarily due to the COVID or similar cases, but more on chronic diseases. With COVID-19, this pandemic, we were not aware what was coming. It was a big shock. We didn't know what we didn't know. But there are some certain aspects and some facts that we know what's going to come for the next 10 years. One of them is the chronic diseases. And in order to really minimize the burden on the healthcare systems, which was actually amplified during the COVID pandemic, we need to really take the necessary actions timely to overcome the barriers and the burden on the healthcare systems, and really making strengthening the resilience of these systems in the coming years. I think the phase 1 has completed, as mentioned earlier, that we have listened to the first outcomes, and it was really inspiring and promising. Now we are entering to the second phase. I'm so proud that second phase, 4 countries from Middle East and Africa that I am responsible from will be joined to this phase 2 study, phase 2 part of this project, and I'm sure that we will see the great results from each and every country. One of them, as Professor mentioned, that Saudi and GCC countries, Gulf countries, and also South Africa and Egypt will be joining. So having said that, the first reports, it was really actually interesting for me to see that all the country reports we have seen, there were a consistent theme. The early prevention, early detection, early screening is the most important need that we should be just intervening all together, because it is coming. We know what is coming. So when you look at some data, OECD reports, and maybe the number one problem could be, as again Professor mentioned, that resourcing and dedicating the right amount of expenditure to this level, expenditure to this area is crucial. As of today, I'm sure that in this room, everywhere across the world, we all understand that prevention is really important in order to minimize the burden. However, still 3% of the total healthcare expenditure is dedicated to the early prevention, early actually screening, early diagnosis of the diseases. So still we believe, we do understand, we are aware. However, when it comes to the resourcing, we are not still there, unfortunately. The second consistent theme actually around these chronic diseases is growing population, and also actually the population is getting older, right? You know, the years, which is very good for the, again, human being. However, we need to really provide those people, whole population, a good healthcare system, which is quite resilient based on our needs. And what we know as of today, I think it is the WHO reports, more than 65% number of people more than over 65 years old is more than 500 million, and will be tripled by 2015. It will be much more than the babies, the children that we are having globally. So we need to really create a world and a system which we can really navigate between the corridors in the right way for our people. Chronic disease, early detection, early prevention, it's not easy because the chronic disease burden, not just from the budget perspective is heavy, but also from the management of the disease. And the pain on the patient side, it's also important because more you live, you shouldn't be living more with the chronic disease and the symptoms and the consequences of that disease. It should be minimized with the right intervention in the right way. Seeing all of them, now while we are building this phase 2, right, 2.0, I think the chronic disease and early detection, early intervention to this disease is the number one priority. It should be the number one priority for each and every stakeholder, partner in this ecosystem. Astrazeneca is a company, a pharmaceutical company, biopharmaceutical company, but we have never positioned ourselves as just providing a pharmaceutical, but we position ourselves more an healthcare solution provider for the patients, for the best of the community, for the best of the society. So because of that, we are very much proud of this project. So we are really looking forward for the second phase, and we have many projects around this in Middle East and Africa, but certainly digital technology will be helping us a lot. We will be utilizing the new technologies, including AI and other technologies. We are also learning a lot, and it is a journey, a common journey together. I'm sure that we will be doing great with all these great partners that we are working in. Thank you so much. I'm stopping here.
Oh. So, thank you very much, Pelin. We have some minutes, so I take the opportunity to ask you a question.
Please,
yes.
please.
So you were talking a bit about that AstraZeneca is a pharma company, but you're not only delivering on pharma. So how would you say that AstraZeneca is prioritizing on a global level early detection?
Yes, I think this is, as mentioned earlier, that this has been a journey that we have been through for the last many years. And especially the digital era, the technology, we are just trying to adapt ourselves, what we are doing and how we are doing. Maybe I can give a couple of examples how we are just internally also pushing the boundaries for ourselves, upscaling our efforts. In Middle East and Africa, very recently, maybe last 2 years, we have started to work on AI for the early screening, early diagnosis of lung cancer, that area, and also heart failure. It was really interesting for me also as a medical doctor. I was never be imagining that technology could be that far, detecting through the X-rays, detecting the lung cancer, the suspicious nodules, or the same looking at the pleural perfusion for heart failure diagnosis through the X-ray scans. Now we are working on it with an AI company in GCC here and also in Turkey for the heart failure, and more countries will be added. Another one, I think in Middle East and Africa, we have huge population. I'm sure that you all know that, close to 2 billion people, really looking into the eyes of the healthcare sector, industry, and all the other players. What can we do? And screening is really important. So in 15 countries, we are really working with the local associations, local regulators, and all the key healthcare professionals and even pharmacists all together for the screening of, for example, for prostate cancer. And also another work, we are partnering with the patients. We are trying to build something that can use easily, like an easy app for them to really get the awareness and the information immediately for themselves, how to help their disease, even diagnosis. And we just realized that how pharmacies is also important. Maybe in the before many years, we were more thinking about healthcare professionals and the hospitals and the associations, but now pharmacies are important, especially in this area. We have observed this during the pandemic period. So many examples I can add more, but certainly this is a journey. This is a bit of internal strengthening as well, ourselves, pushing the boundaries externally, but we are very much happy what we are doing, and we see the future so promising.
Thank you very much, Pelin, and thank you for a very inspirational talk. So, thank you.
Pleasure.
So now we'll move on to the last part of this session, and now we are very curious to hear more about this topic from the caregiver's point of view. So I will welcome Björn Swega, that is the CEO of the Karolinska University Hospital in Sweden, and he will speak about expectations of healthcare in the future, the role of hospitals in integrated care, and also share some inspirational from the journey that Karolinska is on. From not being ranked among the highest, best hospitals in the world just a couple of years ago, now being top 10 and continuing the journey to become the best hospital in the world. Björn Swecare.
Thank you. Thank you for your introduction. And I hope that we'll not get down on next one now. Here we go. And thank you for inviting me to talk about the future, which is not always, future hospital is not always the building, or very seldom the building, even though we have good buildings, at the moment at least. It's about having the cutting edge technology, going specialization with all the technology and all the knowledge that we have now, and about collaboration, which is sort of not doing it on your own, but using the knowledge that's around and how we're going to move on. So Karolinska University Hospital is one of Europe's premier health facilities. We have a partner, which is the university, which is across the street, the Karolinska Institute, and we lead Europe in development and medical breakthroughs. Our vision is that we will cure and relieve tomorrow that no one can cure or relieve today. That's forward thinking. As any university hospital, we have 3 key assignments. So you know, healthcare, clinical research, and the education all are sort of strong and part of our foundation. But as has been talked to earlier today, this works sometimes and not. Here we go. Healthcare is facing major challenges and opportunities. We tend to talk a lot about the challenges, but the opportunities are straight. This leads you to that. You know that you have to do some changes in order to survive. We need to change to use the opportunities to be able to track further. So complex operations need to be organized simply. That's what we have learned. We were very complex many years ago, or 3 years ago. Thank you. And we need to be organized simply. So we have more time with the patients, the students, and to do the research work. We make this organization straightforward and easy to understand, especially during the times of high stress, as we've had in the COVID. But how do you get 15,000 people to solve a most difficult task they've ever faced, which probably the COVID pandemic is or has been? So we need to inform and include. I say over-inform. We need to be extremely data-driven. I talked about that a little bit in the panel earlier. And then care-driven. So you have to mix that together. So a little bit more about the Karolinska. It's one university hospital with 2 sites in Solna on the north side and Huddinge on the south side. It makes us one of the biggest hospital sites in the northern Europe. So it's a world-class healthcare in a new hospital building. Building has helped us, even though it has cost some money, but it's helped us and will help us drive us further. We have sort of high patient and safety and security with single rooms. We have really attractive environments. We have separate flows for patients and staff, and we have emergency and planned healthcare. We also have a new building that's called the Bioclinicum, where we have a hub for, no, this one seems to have gone, a new hub for research and education, where we put in both, mix the clinical education with the newest cutting one, and the one that we opened up sort of just a few months ago, in the end of 21, is the world's first photon counting computer tomography. Is based on silicon technology, and it's being tested now on patients. It's technology that comes from both the technical university, from the Karolinska Institute, and from inside the hospital. Mix it up there and do that with industry. Actually, we're doing that with GE Healthcare, and we're getting some of that. That's really, really good, with low radiation doses and better image quality. We're doing the things in the hospital where we have all our transport or logistics done with robotics. We have in all our floors 29 robotic trucks that cover more than 1,600 transportations per day. And they collect the cleaning charge. They go around driving medicines and tools. They even have their own elevators. And drive very safely. We haven't had an accident yet. So we have strengthened patient integrity with single rooms, which is really good. Not always good with single rooms. We have to make some decisions when do we go double or even quadruple. But this was sort of the mainstream that has helped us. It has its challenges, but this is the future. Like I talked a little bit about the hospital, we have 1,200 beds. We are 15,400 employees. We had to add a little bit of employees. Now we're doing so much around the COVID. We've had over 1 million patient visits. We have a crown factor, which is quite high. And we have 2,600 registered researchers. And we had last year, or the year before, sorry, these are not really updated numbers for that yet, 3,200 scientific papers per year, with a lot of external research contribution. And this is all like I was told in the introduction, the only world ranking that's done on hospitals. We were not on the ranking. We didn't make the top 100 in 2019. So, but in 2021 and 20 and 21, we're in the top 10, and at the moment number 7 globally and number 2 in Europe. We've also been called the best specialized hospital in the Nordics in 8 out of 10 specialities. But one thing that we need to talk about also is the COVID. It has accelerated our transformation, as everybody talks about. The COVID hit Stockholm quite hard. So we've treated with inside the hospital, not on the outpatient clinics, nearly 13,000 patients to date. And we've taken care of about 20% of the COVID patients that have been admitted to hospitals in the whole of Sweden. So at the worst time in the first wave, we had to increase the capacity of the ICU nearly 5 times the normal level. We've also done a lot of PCR tests for the region of Stockholm, where we've been doing that. We've done, to this date, 3.350 million PCR tests. And we've also taken an active role in the vaccination. We have already vaccinated 300,000 of Stockholm citizens and patients. But we're extremely data-driven, and we've used that to work together and to do the production planning as the engine for our stuff. We worked with different programs to do this, make this happen, make this drive us through. And this looks simple, but it's when you look inside the engine, it's extremely complicated with a lot of things. But these things work together. They work now. They work as a principle. Some people have noticed this, and last summer we were voted the smartest hospital in Europe and number 8 globally, being data-driven and with good equipment to do what needs to be done. But as you've heard and you know, the future of healthcare requires cutting-edge technology, advanced specialization, and like I said earlier, collaboration. We need to go together. We need to work together. We need to get the universities, the public, the prevention things, the primary care to work together and collaborate more than we've done ever. We're quite good on precision medicine. We're not talking about this as research. We're doing it now. So sometimes when I talk to people about precision medicine, somewhere there, so in the future, but I say the future is now, at least at the Karolinska University Hospital. We're extremely proud of some of our quality indicators. Here's one of the quality indicators was always the flagship of the university hospitals. Well, that's thoracic surgery, heart surgery. And last year, the numbers will be out in a few weeks, and for 2021. But in 2020, we had the best results in the world in cardiac surgery. Some things are difficult to compare, but these are numbers that you can compare up and down. We also are getting extremely good and specialized in our comprehensive cancer center, which sees a lot of patients and extremely specialized, but still takes care of the patient all the way through. We believe in the same thing as usually, the integrated or the hybrid surgery theaters that we have. We have a lot of them. We use them in a little bit different ways than we were thought in the beginning, but we're still moving very, very fast forward with numbers to lie behind that. We are using more and more automation and robotics. Just in December, we bought 4 new robots into our systems, and they are top of the line. We have a lot of work where we mix together parents, the patients, and the care. And our pediatric cancer app is one of those things that has been up and running for nearly 2 years now, and it's been extremely successful. We use algorithms to try to help us prevent infections. We talk about hospital-acquired infections here. We have algorithms, and I talked a little bit about that in our panel, that help us with that. But once again, working together is our hallmark. We have a lot of chances to work together. One of the things is that we are one of the leading partners in the European University Hospital Alliance. And it is an alliance of 9 leading hospitals in Europe with demonstrated excellence in healthcare, education, and research, where we help each other. We share data, we share knowledge, we have meetings online or in place, depending on what we are doing, and we do courses from each other, and we move further on together. So finishing off, you have to see our main thing is that complex operations need to be organized simply, otherwise they don't work. We need to simplify and reduce the administration. I haven't talked much about that, but we have managed to do that. We need to have leadership from inside the operations, not top-down. We need to enable decision-making with easily accessible data and collaborations with the patient first, the patient in focus. I know that sounds like a sort of a gimmick thing, but we are actually doing that with the patients. And I have not time to talk about that, but I hope to be able to tell at least some of you about that later. So thank you. I think I have 1 minute for a question.
So thank you very much, Björn. So what would you say is your views and your perspectives in the future? What are your dreams for Karolinska in, let's say, 5 years?
Well, I tell my people I work with, don't look 5 years forward. You need to look 2 years, otherwise nobody takes it seriously.
So give us your 2 years perspective then.
Well, our 2 years perspective is that we'll continue to do better. We've be able to help more people, sort of help more people. We've had some waiting lists and we have had some problems. We've sorted them out. We're going now after when we see the COVID has sort of gone or whatever, we're sort of taking a break. Or I think we'll have later this year a time where we don't have waiting lists, a time where we can continue to help other regions in Sweden, other countries, and that's sort of my dreams. And still hold this high quality and higher reputation and find out new things. I know there are a few things in the pipeline that we sort of are going to be world leading in. So this is sort of what we do in the next 2 years.
Perfect. And thank you very much, Björn Swecare.
Thank you.
So with that, we have finished off this session, and I would like to thank all the speakers. And now it's time for a short break again. And we meet back here at 4 o'clock local time and 1 o'clock for you that are online in Central European time. And maybe at this point, we also hope to have with us some watchers from the American time zones. And during this break, there will also be an opportunity for some exercise, since we have Generation PEP here to join us, and they will help us to do some exercise during this break. So see you back in 30 minutes. Cakes and exercise.
Hi everyone, my name is Carolina Klüft. I'm a former Swedish athlete in athletics. I was competing in heptathlon and long jump, but nowadays I'm retired from athletics and working with children's health in an organization called Generation PEP. It's a non-profit organization and I'm the operations manager, and we're working to try to make children move around more, be more physically active, and also eat better to have better food habits. And I'm very honored to be the one that will have this brain breaks with you. I know you have important days and a lot of important things to discuss, and I'm very happy to have this brain breaks with you, where we'll move around a little bit to get up our energy in our body again, and to also activate our brains again after sitting still for a while. So please get up if you can. If you can't, you move what you're able to, of course. And I will start this first brain break with my first day in the heptathlon. And it's 4 events, and you don't have to be nervous now. You're not going to do the full event, of course, but we're going to do easy, small exercises according to the heptathlon. So I'll start with the first day, and the first event in the heptathlon is the hurdles, the 100-meter hurdles. So you will be standing up, and you will be moving the first leg right up, and the second one you will be moving out and forward. So first one and out with the other one. And you can also have your arms, so be careful so not kicking anyone beside you. Just stand here, moving first leg, go up and down, second goes out and forward. Great. Looks like we have some heptathlete talent in the room. Great, so the first event is finished. The second event is the high jump. So you will be standing just straight. You put down one foot and you go up with the knee and the arms. You want to go high, so go up and try to stretch yourself as good as you can. Up. Great. We do a few there. Come on. You look good. And we go up. And we go up. Great. And so the third event in the first day of the heptathlon is the shot put. So you will be standing with your legs a bit aside, and you will be holding your invisible shots put here, and your arms go up here, and then you go down with your knee and you push yourself out and you push. So be careful now, don't hit your friend, and push. Just a few seconds, a few minutes of a brain break will definitely be good for your health. both in the short term and in the long term. Well done. Okay, so the last event is the 200 meter running. So we will be running with our arms quite fast because now it's the 200. So try to move your arms quite fast. If you want to go with your legs, you can be standing a bit and running with small steps on your, just where you're standing, on your spot. And we're running 200 meter. Well, great job. Thank you so much for having this brain break with me, and I will see you again. Have a good day.
Diabetes is a complex disease that places exceptionally high demands on the individual's own ability to self-care. Adults and children living with diabetes must balance their blood sugar levels as close to normal as possible. This is not always easy. Most things affect your blood sugar levels. Diet, activities, work, school, stress, sleep, anger, family, time, and motivation are all things that can have an impact on your diabetes. In the past, blood sugar levels were measured with a blood test, but sticking your finger dozens of times per day is hard. In addition, those who measure their blood sugar levels by using this method do not gain an overall understanding of how their blood sugar levels work, which makes it difficult to understand why these levels vary throughout the day. In 2010, CGM, or Continuous Glucose Monitoring, was introduced. This has led to a revolution in diabetes treatment. By measuring blood sugar levels continuously, you get a much better overview of what happens throughout the day. But now the problem is the opposite. There is so much data coming from each person's sensor that healthcare providers do not have the time to interpret it manually. As a result, neither the patient nor the provider has a structured way of analyzing all the data generated. Due to this, valuable information is lost. This is where we come in. Digital Diabetes Analytics has developed a system that makes it possible to get automated interpretations of each person's health data from their CGM sensors. It also provides treatment recommendations and an analysis of the root causes of each individual's values. The system provides clinical decision support for both the healthcare provider and the patient through an app developed with machine learning and AI technology. For the healthcare provider, the automated interpretation and analyses will help with time savings and contribute to a significantly better basis for adjusting and optimizing the patient's treatment. Through the patient's own entry into DD Analytics mobile application 12Diabetes, the system can increase understanding of how your blood sugar levels vary over time in both short and long term. This frees up time and resources for the healthcare providers and contributes to less stress and increased safety for every person living with type 1 and type 2 diabetes.